in order to do the hip abduction, I'm going to demonstrate how we would do this. To start with, here, the patient is still a little bit too far away from me. So I'll get the patient to come on the bed a little bit closer towards me, just with there we go, like that, perfect. And then this leg, again, shock, this leg is my leg. So this leg, I've got full control of it. Now, in order to elicit the test correctly, what we want to do is bring the hip into about mid-range here. It's not physiologically efficient for a muscle in outer range to try and sustain that contraction. So if you're bringing the hip into full abduction and then telling the patient to hold it there and resisting it, it would probably be challenging for most. So you want to bring it into about mid-range. You don't want to be down here, and you don't want to get the patient from here to push up because we're already in abduction. So you want to bring it passively into about mid-range here. And often what I would say is fix somehow from the pelvis, because what you don't want to do is allow the patient to cheat by dropping into a posterior tilt, lumbar flexion, or just letting the drop of the pelvis come back like this. So you want to just keep it nice, but not too hard, just like a bit of pressure there, just to give them that feedback. Equally, if it's going to be painful, they may commonly just come into a bit of hip flexion to compensate. So from your starting position, fix with this top hand, offset a bit into extension, not too much. We're not bringing it all the way back to here, just offset a bit into extension. And from this mid-range, ask the patient to just lift their leg up. If they can sustain that against gravity for a couple of seconds, then relax, then you're starting to get a bit of an indication of that contractile tolerance. So we're getting them to just hold it in gravity, hold, and then back. Okay, so we know that they can do that now. We know that gravity and the weight of the leg can be sustained with or without pain. And then in order to see if a full stress of it elicits any pain, would get them to hold the leg in the air again, and then you would apply your resistance. And like I said, if you just get the patient to push against me as hard as you can, all the way, keep going, keep going, keep going, and then relax. These aren't the biggest muscles in the world. If your patient's leg is in the air and you're just absolutely leaning down like that, everyone's is going to essentially at some point not being able to sustain it. So make sure that your handling is key. Make sure that the execution of the movement is as optimized as possible. And just to kind of summarize how we do that, leg is close to you, pelvis is fixed, mid-range, and possibly just offset into a little bit of offset into a little bit of extension, and then start the test from there. And that will hopefully give you a little bit of insight into whether or not that patient can tolerate that level of resistance into hip abduction.